Dear colleagues and attendees, dear panelists, welcome to a new session of your mega online course. We are honored today that we have with us great speakers. We have 3 sessions today. Our first session is provided by our dearest senior colleague and professor, Dr. Margaret Coleman. She is the consultant anesthesiologist at Limerick University Hospital. She is also the lead of the pre-operative assessment clinic, Limerick, Ireland. She's going to give us a lecture about the enhanced recovery after surgery for colorectal patients. Dr. Margaret, can you start, please?
Yes, can you see the screen?
Yes, we can see it.
Thank you very much, and thank you very much, Sad, for inviting me to do this talk. Thanks everybody for joining us on a Sunday evening. So I started to become interested in the Enhanced Recovery Program about 14 or 15 years ago, and we have a good ERAS program in Limerick, and recently we developed we got an ERAS nurse involved as well, so we are looking forward to doing a lot more work with her in the future. So what is ERAS? Well, some of you will be using some of the ERAS protocols, some of you will be using very few of them, and some of you mightn't be using any at all. So for those who aren't familiar with ERAS, it really is taking everything that we used to do in the 90s in the peri-operative period and turning it on its head. So it's a multimodal and multidisciplinary program, which makes it a little bit busy and a little bit difficult to set up when you're beginning in the first place. It started out by Henrik Kellet, a surgeon from Denmark, and developed really in the Americas because it decreased postoperative complications, sped up recovery, and promoted early discharge. And this suited the private hospitals, so they got patients out rapidly and got more patients into the bed, so more money was made. So it was initially started really for finance purposes, but they did find that obviously as you got patients out earlier, they did a lot better. So it uses evidence-based medicine, and things are changing all the time. They're guidelines, not tramlines, and when you set up an ERAS program, sometimes you just need to tweak things a little bit so it suits your own institution. So this is one of Henrik Kellet's articles. So this was 2 days after an open sigmoidectomy, and it was in 2003. So I went to a talk that he did back in the late 90s when I was a fellow in Toronto. So he was pushing this from an early stage. Things have changed a lot since then, but the good thing was he was a surgeon, and oftentimes you'd find that surgeons listen to surgeons a lot more than they listen to anaesthetists. So what have we been doing to our patients? Well, to put it sort of simply and bluntly, we were starving them and dehydrating them, then taking them to theatre, drowning them, and leaving them in the bed for about 10 days post-operatively. So we're trying to turn all of that on its head. What keeps a patient in hospital? Well, so they've had their operation, they're sore, they get opioids, then they start to vomit, they get an ileus. If they've got an ileus, they're not getting out of their bed. Lack of mobility makes their ileus worse, more nausea and vomiting, and it becomes a bit of a vicious circle. And then you get an increase in your, say, post-operative morbidity because of not being able to mobilize, respiratory issues, etc. So these are the central elements that we're trying to deal with in ERAS. So when you start a program, there's like up to 22 essential components, some slightly more important than others, but it really is, your aim is to try to get up to at least 80% of the components in your ERAS program. There are some barriers to implementation, as you can imagine. Then develop a guideline, again, not a tramline, based on your best evidence, and sometimes consensus. And again, you might need to tailor it to your own institution. then set up an education program for everybody. So currently the excuses are, well, they're unaware of guidelines or the literature. Really, you know, they're everywhere, so you shouldn't really be unaware of it at this stage. The evidence is very convincing. Now there are thousands of articles on ERAS, and expensive. Certain things can be expensive. Certainly, if you have an enhanced recovery nurse, yes, that's an expense. But the cost savings in, you know, decreasing length of stay or decreasing any of the complications that occur perioperatively, you know, they are very expensive. But the latter three are the big issues: lack of buy-in from everybody. So, you know, I mean, we're all great at trying out new drugs, or surgeons are great at trying out new GIA 60s and whatever for taking out bits of bowel, but we can be really intransigent when it comes to, you know, changing our old practices. And say, you know, a surgeon will say, well, my patients do fine with the nasogastric tube. So you say, well, they could even be more marvelous if they didn't have a nasogastric tube. So it's all about just trying to change our own really long-held views on things that we think are okay, but maybe aren't. So lots of evidence out there, anywhere you look, thousands of patients included now. So decreased length of stay by 30 to 50%. Sometimes patients just do better, but they don't necessarily leave the hospital. It depends on how pushed you are for beds, etc., and maybe, you know, social issues as well. But there is a 30 to 50% decrease in 30-day morbidity, which is obviously very important for, you know, patient care, but also cost. Decrease in readmission rate, and readmission rate is very much a KPI, especially in the United States. And you know, high savings per patient, mainly due to the decrease in postoperative complications. So it's all about multidisciplinary collaboration. So you've got to look at your doctors, so your surgeons, your anaesthetists, your nurses are really important to get on board, as are your managers and allied health staff to a lesser degree. You're using evidence-based recommendations and protocols. And then you have to involve the patient's family and themselves as well. They have to be brought on and given some responsibility in the whole thing too. Everybody really, the colorectal group are, you know, they're all eligible for ERAS, and it's mainly colorectal surgery that I'm going to be talking about today. But with little tweaks, ERAS can be used in practically all areas of surgery. So preoperative assessment, it starts there, it all starts there, and it's where you develop a relationship with your patients. You optimize them from a cardiovascular, respiratory point of view, all the stuff that we all know. We give them IV iron. I'm not sure if we'll have to change that after the PREVENT trial showed no improvement in outcomes by giving them IV iron. But maybe we could look at giving it to them before they go home if they have a low ferritin level. They should stop smoking. Maybe if you see them just a week beforehand, it could be worse to stop them smoking at that point. And we do need to be aware of their alcohol intake. Certainly, you know, it's an issue in Ireland. You can find that post-operatively they fall into a heap. Low saturations, tachycardia, you're not quite sure what's going on, you think they're septic, and it's really that they're in the DTs. So there is a 10% mortality from developing the DTs post-operatively. So, you know, reducing people's alcohol intake is really important, and we get that done at pre-assessment. And we give them pre-operative drinks and some Hibby scrub to decrease post-operative infections, and I'll talk about the drinks later. So you tell them what's going to happen to them, and you address their expectations. Now, I do find sometimes that people are under the misapprehension that because they've got, it's a keyhole surgery, that it's a really small operation. So I reiterate that it's major surgery they're having, and that, you know, the idea that they'll have no pain, you know, I do not tell them that. I tell them they'll know they had something done, but it won't be too bad. And with that, they're quite happy with that. And that's how it works out. You tell them that they'll be expected to get out of bed, that they'll be expected to walk about the place. They need to bring in some chewing gum with them, some jelly sweets with them, something to keep them occupied in the perioperative period. And we provide them with information, surgical information about what's been done and the anesthetic, PCA stuff, all of that. For any of you who've tried to tweak your preoperative fasting guidelines, you'll feel my pain. It's something that is one of the hardest things to change in any hospital setting. So we've had the 2 hours fasting for clear fluids in our hospital since 2006. We recently rechanged them to have them as feeding guidelines rather than fasting guidelines. Still, patients who don't come through preoperative assessment are still coming to theatre, and it's been 12 to 16 hours nearly before they've had fluids. This is really bad for them. It makes them awful miserable, anxious, and, you know, they are dehydrated when you put them to sleep. So we started sending out letters to them to say that they could have clear fluids before their operation. Very clear instructions. They could have tea, coffee with a drop of milk in it, you know, my wadi, something like that. They still came in not taking any clear fluids. So I went down to the secretary's department and asked them, were they sending the letters out? And they said, yes, they were sending the letters out. And then they said, oh, but everybody rings in wondering about the fasting of the fluids. And I said, what do you tell them? And they said, oh, we tell them that they have to fast from midnight. Same as always. So sometimes you fall at the last hurdle. So I decided the best thing to do is just give them the fluids when they come to preoperative assessment. Now we pretty much see all of our major cases in preoperative assessment. So that's got around that problem. So they should come to you in a metabolically fed state. And most of the time, the first patient of the day has had more fluids on board than me. This is a nice little graph that shows that you need to have 200 mils in your stomach before you're going to regurgitate. And our gastric volume is really down to almost nothing after an hour. And in many of the pediatric hospitals now, there's been some nice studies going on where they give them a drink when they come into the hospital and bring them down to theatre. So this is a problem, and sometimes the problem, surgeons don't really care, but sometimes our own colleagues can be a bit intransigent about this as well. And when I was changing around the fasting to the feeding guidelines, some people said they weren't comfortable with it. When I explained that all of their patients coming through preoperative assessment had actually been getting 400 mils of clear fluid in the morning before their surgery, and they didn't really know about it, it changed their mind, and we don't have aspirations, thank God. So this is what we give them. It's carbohydrate loading, so it's not just fluid, it's simple maltodextrin. And on the right-hand side is a bowl of pasta, which you would have if you were running a marathon. Now, sending somebody for major colorectal surgery is pretty much running a marathon, you know, physiologically. So we give them this. We give them 6 bottles of it. They have 4 the night before and 2 in the morning. It's nice stuff. It tastes a little bit like Fanta lemon. And it decreases their insulin resistance. So it's a marker of surgical stress. It improves their comfort, decreases thirst. It's quite nice to drink. And interestingly, it decreases postoperative nausea and vomiting. And there's earlier return of bowel function. So a lot of these things, you know, with the feeding and the way that we treat the bowel is opposite to what we used to do in the past. So we used to not give it any food beforehand, not give it any drink beforehand, put a nasogastric tube down, suck everything out of it, and not feed it for days afterwards. And we thought that that would improve your bowel function. But the opposite is true. So you feed it beforehand, you make it seem like nothing bad happened to it. You give antiemetics, you don't stick any pieces of plastic into the gut, you don't handle it. So the laparoscopic approach, and you feed it early and get people up and around and moving. That's where you get better return of bowel function, like nothing really happened to it. And you do get a shortened length of stay from preoperative carbohydrate loading. Fluid shifts, the days of putting people to sleep and them losing their blood pressure because they've had bowel prep all day the day before and are dehydrated are thankfully gone. We still give a little bit of bowel prep to people who are having very low anterior sections and are going to have a defunctioning ileostomy. There's been some talk recently from the Mayo Clinic that perhaps they are concerned about not giving bowel prep because of the fact that some of the malignant cells can still hang around in the gut post-op. So just watch this space a little bit on that front. But certainly not giving full bowel prep is a lot nicer for the patients and they're a lot more hemodynamically stable. They all get chlorhexidine to have a couple of showers in, and we clip the hair instead of shaving. Antibiotics are given prior to incision, and indeed if they've been on the table for like 4 to 5 hours, we give them a second dose, and you avoid hypothermia. Hypothermia is a terror for developing wound infection. One of the huge big areas that have improved in the last number of years has been the laparoscopic approach. So this decreases our complication rate by like up to 17%. And 17% like is a huge amount in any study. Surgeons who do a high surgical caseload also have lower complications rates. So as I was talking about earlier, nasogastric tubes, they are terrible for your gut. They're terrible to have a piece of plastic stuck down the back of your throat for several days post-operatively. They're uncomfortable, and if you do not put them in, you get an earlier recovery of gut function. And there's fewer pulmonary complications, which I guess is probably because it does affect your gag reflex a little bit and affects the your epiglottic closure. So if you don't use them, they've better outcomes. There's the odd one that will need a nasogastric tube, perhaps somebody who has a big tumor and there's a bit of obstruction there or whatever. But really, you'd only find yourself putting one down once every 6 months or that. So really they shouldn't be used at all as a standard of care. Drains should be avoided. They're still kind of put in based on surgical consensus for the APRs or the low APRs, but really there's no difference in mortality or anastomotic leak rate associated with having a drain in as opposed to not having a drain in. And they can be sore and they're a bit cumbersome when you're mobilizing. TAPBlocks. I'm a big proponent of TAPBlocks. For those who don't do them, I'd say start doing them. Start maybe on people who don't really need them. So, if you're doing a laparoscopic appendectomies or lap choles, just start doing your TAPBlocks. If they don't work, it's no biggie. Then, you just use morphine like you normally would. So they decrease your morphine requirements. They decrease your postoperative nausea and vomiting because of that, improve your mobility. You do need to warn patients the following day, about 24 hours afterwards. It starts to wear off. They can get a little bit sore, but they really are, it's very hard to come up against complication with a TAPBlock. So I don't use any fancy needles. I just use one of an 18 or a 16 gauge ordinary long IV catheter or cannula, one of the ones that would be non-safety, and take off the catheter from the outside of it and just use the needle. And you get, very good views with the ultrasound machine. It's cheap, it's cheerful, and it's a nice, fast way of doing it. So really, you know, just practice on people who don't particularly need it, and then use it on these. If you are using a TAPBlock, will work for your midline incisions as well as the laparoscopic port incisions. If you're using a rectus sheath block, that will only work for midline. So the TAP kind of works for everything. You can consider using a pre-peritoneal wound infusion catheter, and Bertoglio in 2012 has a nice paper on that. You've got to convince the surgeon to close the peritoneum, and then you put the catheter over it, so it gets your peritoneal pain, your muscular pain, and your skin. So these are kind of useful if you've turned from a laparoscopic to an open approach and you weren't expecting it. These can be useful, nice little kits available for those. And this study compared it to epidurals, and it was shown to be non-inferior. Now, you know, there was a few little issues with the study, so I wouldn't say it's as good as an epidural, but they are useful for multimodal approach. So it's all about getting down your morphine requirements, really. So for every 3 to 4 milligrams, there's one clinically significant side effect. And I guess we'd all probably agree with that. So multimodal analgesia is where you use lots of different analgesics from different analgesic families in low doses, so you get the benefits without the side effects. So you've got a good choice of things to use. So I would use gabapentin 600 milligrams preoperatively in all of the patients. It works very well for postoperative pain relief. It can make them a little bit dizzy, and I warned them about that beforehand. Plus or minus anti-inflammatories, and we'll talk about them in a little bit. We'll talk about epidurals as well. All of mine get local anesthetic blocks, TAPBlock. And I've started to use intravenous lignocaine as a bolus and as an infusion. Everybody gets paracetamol and ketamine. And I still use a PCA, but patients use about 1 milligram an hour of it. It's more to have it there in case they need it for mobilization, etc. And I use double antiemetic cover for all of these because it's really important that they get back to eating and drinking as fast as you can. So intraoperative lignocaine. So there's a lot of work done on this. I see in the bottom of the screen there, Lauren Dunn and Dr. Vigneault have done 2 nice meta-analysis on intraoperative lignocaine use. It decreases pain, decreases your opioid requirements, and decreases ileus and postoperative nausea and vomiting, and thus length of stay. I give 100 milligrams pre-incision. So the idea is that pre-incision, it decreases that hyperalgesia associated with the sort of start of the pain from the incision, and then continue with an infusion. The dose that you use, all of the studies vary an awful lot depending on the type of surgery. Some of us was cardiac surgery, some of it was colorectal, but people were using infusion rates that were varying from 1 up to 7 milligrams per kilogram per hour, huge infusion rates. When I started off early, I just wanted to be careful about it. So I use a milligram per kilogram to 1.5 milligrams per kilogram per hour intraoperatively. And I keep it going until the end of when they leave the postoperative recovery room. Now, Svensson at the bottom there would claim that it was as good as a thoracic epidural in his study. Again, there were some issues with that. But you'd have to say certainly it's an awful lot less complex than a thoracic epidural and less risky. So it's something that you should consider using. I find it really hard to get the NCHDs to give the bolus dose, mind you, despite the fact that we used to give 100 milligrams to people with ventricular tachycardia and no blood pressure some years ago. So it's quite hard to get people to actually give the incision bolus for some reason. It's pretty safe. I haven't had any problems with it. Can give them a bradycardia, but it's not dose related. Obviously, if you have somebody with, issues with, heart block and that sort of thing, you would keep away from the lignocaine. Just a little word of warning: if you're using gabapentin and intraoperative lignocaine and the TAPBlocks and so on, they do take a bit longer to wake up. And if you're not there to turn off or down the sevoflurane from 2% when the surgeon is closing, you'll be there for 20 minutes afterwards, waking the patient up. Some of the studies continue the lignocaine into the postoperative period on the ward. I don't think our nurses on the ward would appreciate that, so we've never done that. Ketamine, horse tranquilizer, has analgesic and anti-inflammatory effects. It's sort of an old drug. It went out of favour, certainly in Ireland, for many years, but has come back in a little bit and is very useful, especially for people who've been on long-term opioids or, very low pain thresholds. It does decrease your opioid requirement. Some use it as infusions. Again, my practice would be to give 0.5 milligram per kilogram as a pre-incision dose. That's sort of, so 0.5 to 1 milligram per kilogram gives analgesic effects without having the neuropsychiatric side effects that you can get with ketamine, which can be very unpleasant. Anti-inflammatories, it's about the only thing myself and my surgeon argue a little bit about. There was a study from JAMA Surgery a few years ago, and the headline was, anti-inflammatories cause anastomotic breakdown. So he was waving this at me. It was, there in Twitter. So when you actually go and look at the paper, there was 13,000 patients, yes, and there was anastomotic leakage of 33%, which was, all very terrible. But when you look at it, this was really what it should have said was NSAIDs are safe in elective colorectal surgery, but that's not quite as fancy. It's not as headline grabbing. Yes, they did have a 33% anastomotic leakage associated with emergency colorectal surgery, perhaps associated with NSAIDs. But you shouldn't really be giving NSAIDs to people who are having emergency colorectal surgery anyway. And this was a mega data article, so they didn't mention what type of NSAID was used, COX-1, COX-2, how long they were on it for, what the doses were, and any anastomotic leakage up to 6 months was considered an anastomotic leakage. So in theory, you could have got 1 dose of celecoxib in theatre, and then you had leakage 6 months later, and the two were associated with each other. So it was a poor article, but it is something that the surgeons will be waving about at you. On saying that, you do need to take each individual patient in their own merit. So if they have renal dysfunction, heart disease, CCF, all of that sort of thing. If you are going to use it, if there's no contraindications, COX-2s are probably better. Ketorolac and celecoxib would probably be the better of the NSAIDs. In fact, some would suggest that celecoxib has got a good effect on cancer recurrence. But do add a PPI, because you can run into a bit of difficulty, especially if they're not eating an awful lot in the post-operative period. Paracetamol works well with the NSAIDs. IV for the first few doses, you get better plasma levels. And then make sure they're on it regularly afterwards. And I leave them on gabapentin for 3 to 5 days post-operatively, 300 milligrams BD, or if they're a very big person, maybe 300 milligrams TDS. And these should be written up for the patients to get if they're not in pain. Okay, so you don't want them to be getting it on a PRN basis, because once they're sore, it's just harder to get on top of it. So they all get double antiemetic cover. Now, I don't do this in all patients, but I do in the major colorectal stuff. So even if they don't have any history of postoperative nausea and vomiting, they all get dexamethasone, 8 milligrams, best given at the beginning of the case. And so dexamethasone has got a lot of other properties that aren't just antiemetic. So you decrease your opioid requirements with it. And they feel really well and they're hungry afterwards. So it's a lot easier to get them to start taking a little bit of food. It's not something that'll continue in the post-operative period because it probably does increase their risks of developing post-operative infection if you leave them on it for post-op. The other caveat would be the diabetics. I would still give it to, I think the benefit that you get out of it outweighs the risks in the non-insulin dependent diabetics. But I might cut it down to 4 milligrams, especially if they were a smaller person. I wouldn't give it in somebody who's an insulin dependent diabetic, to be honest, because you can get that big shoot in your blood sugar levels. I give granisetron rather than ondansetron because it is it's a 24-hour version of the 5-HT3 antagonists, and it's best given towards the end of the case. And that's a milligram dose. The dosages you can give between 1 and 3 milligrams, but studies would suggest there's no real benefit to giving any more than 1. And I write them up for that for a few days post-operatively as well. So again, you know, as you well know, when you get sick, it's too late. So the idea is to prevent them from getting sick. So they get a dose of that at 8 o'clock every morning for 3 days post-op as well. Fluid management. Well, so in the 90s, the mantra was a litre an hour. You know, and then we put them on 120 mils an hour after that. So we were drowning the patients, and that fluid was going into their lungs, the cardiovascular system, a lot of it into the bowel, causing bowel edema and ileus. So we use an awful lot less fluid than in the past. Low volume maintenance, 1 to 2 mils per kilo per hour. I find it hard to even get to that low. Normally after 3 or 4 hours, they have had a litre and a half as a rule, you know, in an uncomplicated case. Should we use goal-directed fluid therapy? We don't, or I don't. The early studies, you know, did prove or show that that the complication rate was lower using goal-directed therapy, and they were using fluid replacement to cardiac output and also sometimes inotropes as well. But the earlier studies were comparing goal-directed type therapy to what we used to use in the 90s. So there wasn't really comparing like with like. The recent optimized trial, which is, you know, last year, looked at goal-directed therapy, and it compared it to, you know, what we use now is, well, it's not right to call it restrictive fluid therapy, more judicious fluid therapy. Then there wasn't a benefit to using goal-directed therapy, and it's busy, and it's you know, it's expensive. So if you're just cognizant of your fluids and you're not liberal with your fluids, then that's sort of what you want to aim for. As I said, 3 or 4 hour operation, aim to a litre and a half in, just use your fluid really to flush in your drugs. Post-op, you're accepting a low urinary output, both intra and post-op. So 0.5 mils per kilo per hour is fine. Recent studies would suggest 0.3. But you do need to make a plan for the ward, because, you know, we've got ultimate control in theatre and in the recovery room, but all of this can, you know, fall into a heap when it goes to the ward and an intern comes to see the patient because they've got oliguria. So fluid overload is independently associated with problems post-operatively. So you can see here, there's a linear association between the amount of fluid you give and the complication rate there on the left-hand side. You'd say, how could somebody give 6 litres of fluid? Well, it's easy enough, really, if you give a litre an hour and put them on 120 mils an hour post-op. After 24 hours, that's your 6 litres. Now, some of these complications are only small, but some of them wouldn't be quite as small. So we just need to be a bit tighter on our fluid management. Now, you do want to be careful that you're not giving them too little either, because, you know, some of these will be elderly on antihypertensives, and, you know, you don't want to tip them over into renal failure either. So there's a happy medium there. So I don't put them on any more than 50 mils of Hartmann's an hour. And so it is easy to say, don't give them any fluid, but you know, there will be issues in the recovery room. If they need a bit of fluid, give them a small bolus, give them 150 to 200 mils. That normally sorts them out. And on the ward, again, make it clear that if there's a problem, then give them 200 mils, and not to be putting them on 120 to 150 mils an hour and walking away, because that's what does happen a fair bit out on the ward. Excuse me, you shouldn't, you know, you should be looking at things like heart rate and blood pressure as well as urinary output, because, you know, we do retain our urine post-op because of ADH. And so, you know, it does sort itself out. If you can decrease their IV fluids as soon as possible, which we do the following morning, then you will sort out your own volume status. So there's a nice paper recently that just showed that, you know, people, they drink if they're thirsty, they don't if they won't, and they end up getting a lot less fluids if they're allowed to take what they need themselves. So that's what you're aiming for the following morning. Neuromuscular blockade, intraoperatively, we do try to keep their insufflation pressures low. I find it difficult to persuade the surgeons to keep their insufflation pressures low. If you do, it's supposed to dry out the bowel a lot less and cause less pain post-operatively. If they do, you do need regular neuromuscular blockade, and you use your train of 4 just to keep the diaphragm from moving, because the diaphragm moves a lot. It's a lot easier to see it in a laparoscopic approach than you see it on your ventilator. And sometimes you do need sugammadex then to reverse them. It's expensive, but it is great. And it's great really for keeping them very cardiovascular stable if you've got somebody who's got cardiovascular disease. And it is also great in obesity. They have much better respiratory function after sugammadex than neostigmine and glycopyrrolate. Now, epidural or not, well, in laparoscopic surgery, no epidurals, okay? They decrease your length of stay, they slower return of bowel function, and there's no improvement in pulmonary function. So nobody uses epidurals in laparoscopic surgery anymore. It does remain an option in open surgery, but we all know that well-working epidural is a thing of great beauty, but one that kind of half works or has got the top of the incision isn't covered is a bit of a nightmare, because they go onto the ward, they're complaining, the nurses won't give them opioids because they have an epidural in, somebody has to go and top it up, and it just gets really messy. The resource use is high, and there's no doubt that they get a lot more fluid than they would if they didn't have an epidural in. In theatre, we can control that by just giving them inotropes, or, you know, ephedrine, phenylephrine, or whatever. But, you know, on the wards, they will get more fluids. And we've already spoken about the issues with fluids. And unless you've got a big, high nursing to patient ratio, your mobilization is going to be a problem. So it does still remain a part of the ERAS protocols. But as we use multimodal analgesia, like the lignocaine, the ketamines, and so on and so forth, it's, you know, people are questioning whether or not you should use an epidural or not. So it's a little bit out there. Apologies to all the men here this evening. Feeding patients post-operatively is one of the most important sort of independent parts of your enhanced recovery program. So feeding them and mobilizing them have been shown from the POWER trial to be two very important independent components of the ERAS protocol. So hard enough to get some surgeons to feed their patients post-operatively. So when we were wondering what we would use, we thought about using Ensure, you know, high high protein drinks that elderly people have to drink if they're very malnourished, but really they taste horrible. So we came up with, in conjunction with the dietitians, found us Nourish. It used to be called Paganini. It was originally made for athletes post-operatively. It's high in carbohydrate, high in protein, and it tastes really nice. When it was called Paganini, we could never find it because the nurses ate it all. But when they changed it to Nourish, nobody was interested anymore. So we give this to the patients the night of their surgery, and we give them some fluids as well. The following morning, they get some more, and if everything is staying down, they get some tea and toast, and they have a kind of a sloppy lunch. So if you can feed people, their gut responds well, and there's a lot less problems with ileus, anastomotic dehiscence, pneumonias, etc. So they have a much better outcome. So, you know, something like that is quite nice and easy. It's food, but it's not food. And if you're trying to persuade your surgeons to feed them early, that's the sort of thing that is good to start off with. Also things like jellies, jelly tots, jelly babies, they're food, but they're not food, but it's nice for the patients. They enjoy them. I enjoy taking it off them the following morning. And, it really just turns into sugary water when it hits their stomach. So it's not hard on them. Chewing gum is a nice, cheap and easy way of dealing with reducing ileus. So anybody who chews gum knows that their stomach starts to gurgle afterwards because their stomach is waiting for something to come down to it. So it gets your gut going. A couple of nice little studies. It's cheap and easy, and it's quite nice to chew a little bit of gum, especially after you've been sucking sevoflurane for 3 or 4 hours. So everybody brings in their own gum. Try and get the urinary catheter out as early as you can. If they're very low anterior resection, maybe they stay in for 48 hours. End pajama paralysis. Patients are told to bring in their street clothes with them. Things like, sweatpants and that sort of thing, t-shirt and sweatpants. So once you're wearing those, you're not quite as inclined to go back into bed, and they are going to be doing trips of the corridor. The apologies for the impossible to read writing, but that's the dangers of staying in bed, and it's from 1965. So even back then, the dangers of immobilization were seen. So people need to get up, get dressed. They dangle their feet out the side of the bed that night. They get out, they have all their meals in a chair, no arguing, and they walk the corridor, aiming for at least 1,000 steps on day one. We have Fitbits for them. They get quite competitive. Who had the most steps? Did I have more steps than you did? They get right annoyed if the Fitbit doesn't count their steps. One 82-year-old asked her daughter for one of them for Christmas after she'd had one of them in the preoperative assessment or in the post-operative care unit. So it just gives people, I suppose, something to aim for, and it passes the time as well. So they get up and they do several laps of the corridor and try to get 1,000 steps in. We also give them coffee. As you well know, when you have coffee in the morning, it gets your gut going. So it's just all of these little things. For the future, prehabilitation, perhaps, but you're going to have to get patients, 6 to 8 weeks prior to their surgery, which for us is not going to happen in the near future anyway. The liposomal slow-release local anesthetics will be interesting in the TAPBlocks. I believe they've been passed by the FDA, but not European Medicine Agency as of yet. The wearables and telemedicine and dissemination of your ERAS practices outside the hospital is something for the future. There is no reason why patients can't go home and be a little bit uncomfortable at home as opposed to being in a ward. And, if they have wearables that you can look at, then, that is a prospect for the future. So in conclusion, thank you very much for listening to all of this. It was a rapid gallop through it all. It is a paradigm shift in perioperative care compared to what we used to do in the 1990s. Setting it up can be a little bit frustrating, and you do need some patience. But you know, there is no magic bullet, and it's all about, you know, trying to get 80% adherence to the protocols that you're using. It is multidisciplinary. It can be hard to get all your surgeons on board. It's slow, but it does work. And you know, if you can get buy-in, the benefits are very impressive. So good luck with starting that off if you're not there already. Good. Any questions? Or am I supposed to ask questions?
First of all, thank you, Dr. Margaret, for the informative, detailed lecture. Actually, I think one of the most challenging thing is change of practice.
Mm-hmm.
Someone is used to doing something, it's difficult to make them change it. So we don't have many questions. One of things, are there any complication for enhanced recovery?
No, I mean, it's all about decreasing your complication rate. I suppose each of the individual things, for example, drugs, all have their individual complications that can occur, but you know, we should be all aware of those at the time. But not doing enhanced recovery has a high complication rate, i.e., you know, dehydrating them, drowning them, immobilizing them, all of those kind of things, giving people, you know, opioids and nothing else. That is what has a high complication rate. So, you know, other than the individual drugs that you can use, you know, you can run into troubles with anti-inflammatories, etc. You know, then no, there isn't. You know, it's all about decreasing your complication rate.
Okay. Another question. What do you think about droperidol for nausea and vomiting treatment?
About what?
Droperidol.
Droperidol, yeah. Well, I mean, droperidol was taken off us some years ago because of you know, a black box warning regarding cardiac problems with it. So it has never really come back you know, to us. And I guess with the dexamethasone and the improvement in the 5-HT3s since we lost droperidol, there's not an appetite for it coming back. I do believe you can get it in lower doses now, but we don't really use it anymore.
Okay. We have many questions. I'll ask one more, and the rest we'll do in the end of the sessions, if you don't mind.
Yeah.
So why not ondansetron for postoperative nausea and vomiting?
Well, because like ondansetron, you have to give 3 times a day, right? So it's 8 hourly. And there's no doubt that all the studies would say that if you, if people get sick, it's too late. So it's really about preventing them getting sick. So if you can use granisetron, right, is a 24-hour version of ondansetron, essentially. So, you know, if you have nothing else, if you don't have granisetron, then ondansetron is fine. But people kind of nearly need to get it before they're nauseated. And when they go to the ward, that's not what happens, you know. So if you have Kytril and granisetron and you can use it, then it's preventative for 24 hours. In actual fact, there's newer ones now, losantron, and that they come out of the chemotherapy people. And there's some now that panisatron lasts 36, 48 hours. So if we can get our hands on that, it will be even better. But it's not that you can't use it, you can, but it only lasts for 8 hours, or is preventative for 8 hours, whereas granisetron is 24 hours.
Thank you, Dr. Margaret.